I'm going to be talking about minimizing treatment duration. I'm not really going to talk about minimizing treatment doses. I think that's probably not as relevant a topic. Here are my disclosures. I do a lot of clinical trials with the new drugs, as well as some consulting for the companies that develop them. So I'm going to talk about first whether or not we need shorter therapy. Then if we do need shorter therapy, can we predict from modeling what that looks like? So how long what is the minimum duration that we need? And do the data agree with the theory? So how short can we actually go if we use a DAA approach alone? And if we don't use a DAA approach, so if we use alternative approaches, can we get further along? Oh, sorry. So first of all, do we need shorter therapy? So I would say there are pros to this and arguably not cons. I think we all agree that if you can do everything, all things being equal, shorter is probably better, but I guess at least non-pros, so things that might argue against some of the pros. So the first pro is that obviously it's easier for patients. Theoretically, if you're exposed to drug for less time, there's potential for reduced toxicity, maybe increased adherence, simplicity for patients, and they prefer to have shorter therapy. I think that's generally true. But arguably, the therapies that we already have are extremely easy and very safe to take. So overtreatment, we already know, and I'll show you that we are overtreating most people. We know that overtreatment is safe because the toxicity of these drugs is extremely low. Toxicity could actually increase with shorter therapy. If your shorter therapy involves extra drugs, you may actually have greater toxicity with a shorter therapy. Adherence may not change. Once the threshold for where adherence change seems to be somewhere between 6 and 12 weeks. So we're probably right around the threshold where reducing duration may have an effect, but probably only a significant reduction, getting down to about 4 weeks, would really likely change adherence. And as I'll show you, if you try to shorten therapy and you can't do it in everyone, then you actually might increase complexity, which is potentially an issue for patients and providers. On the treater side, it's easier for treaters. There's greater capacity if the treatment is shorter, and potentially you have to do less monitoring. But on the flip side, the therapies are really easy and safe. There's limited, or arguably we heard this morning, potentially even no monitoring necessary with even our current therapies. And if that's true, then really therapy has pretty limited impact on capacity. It's really the monitoring that requires the capacity. So again, that may not be a huge issue. The biggest argument that's always pushed forward for shortening treatment is that fewer doses equals fewer dollars, but that's really not true. There's really no reason that that's actually true. Andrew is going to talk about this next, and has done really a lot of the groundbreaking work in this, but showing us that these DAs are extremely cheap to produce, and really new drugs could actually increase the cost. If you add a third drug to shorten the duration of therapy, there's no guarantee that's actually going to reduce the cost, and it may actually increase the cost. So I think this notion in certain areas of the world where people pay for their own drugs, arguably if you're using the current drugs we have, being able to shorten therapy in some individuals may be worthwhile, and I'll show you some data on that. But overall, I wouldn't say that idea, that rationale for shortening therapy is a particularly good one. And the other con, and of course this is the biggest con of shortening therapy, is that relapse will almost always increase when you shorten therapy. So I guess if you look at this overall, the benefits are less obvious than one might initially assume of shortening therapy now that we've already got very highly effective, relatively short therapy. So should we aim for shorter therapy? I would say all things being equal, yes, but all things being equal is a very high bar to set. So that has to assume that we have similar or identical SVR rates, we have a similar or better safety profile, and we have similar complexity to treatment, because I would really make the argument that simplicity really may trump short, and over-treating some people so we have simple treatment paradigms might be a more useful approach. So where is short therapy going to be most important? Certainly in the harder to reach populations, so people who have unstable housing, people who inject drugs, incarcerated populations, especially we heard yesterday from Andrew, if you can deliver a full course of therapy during someone's relatively short stay in a prison, that might be advantageous. Potentially in regions where you have limited capacity, so in some low and middle income countries, or even in countries that have higher income but are dealing with remote or rural communities where accessing patients and providers may be a challenge. These are probably the areas for treating baby boomers in tertiary care hospitals. It probably doesn't matter if we shorten therapy very much. So can we predict the minimum duration? If we're going to think about shortening, are there data to help with this? Well, if we look at what happens to someone on antiviral therapy, this sort of comes from the interferon era, but it actually applies to DAAs as well, that you have this biphasic decline. You have this initial first phase, which is the block of viral production. So that's blocking new viral production. And then you have this second, which is always a slower phase, whatever type of drug you're using. And this was initially thought to be due to clearance of infected cells through immune mechanisms. What seems to be true when you use DAAs is that it's probably also cure of infected cells. And the difference there is that clearance of infected cells is probably a slower process. So you may actually be able to cure infected cells. This has certainly been shown in vitro and probably is true in vivo based on modeling the mechanism of action of different drugs. So when we target therapy, we get to the lower limit of detection in the serum, and that's what we say when we say someone has undetectable HCV RNA. But of course, the goal of therapy is to get down much lower than that to actually get to the lower limit of detection in the body, or what some people call the cure boundary. Now, importantly, we don't really know what happens between these two lines. So we know that it's estimated that there's quite actually a lot of virus that still persists in the body between this lower limit of detection in the serum and eliminating the virus from the body. And Alan Perelson's group has done some modeling to suggest that there may be as much as 5 logs of virus in this after you clear virus from the serum. So it's showing us that there's still a lot of virus there. Now, the thing is that this second phase is a much more variable thing than the first phase. The first phase about the block of viral production is really intrinsic to the drug that you're using. The second phase is partially to do with the drug, but more to do with the host. And so it's affected by the presence of cirrhosis. It's probably affected by the presence of treatment experience. It may be affected by the genetics of the host, so the interferon lambda 4 or IL-28B genotype. It's almost certainly affected by the presence of resistant variants. So if they're low level at baseline, they're still there and they are slowing the final particularly cure of infected cells. And it also probably depends somewhat on the drug, whether you have a single or multiple mechanisms of action. And so if you distinguish some of the DAAs, for example, if you use a polymerase inhibitor like sofosbuvir, that clearly has a single mechanism of action that inhibits the viral polymerase and nothing else. If you take a protease or an NS5A inhibitor, at least in vitro studies suggest that they both block, in one case, the protease, and in another, the NS5A, assembly and probably replication. And by having 2 mechanisms of action, you may actually have a greater effect on the second phase. And then finally, ribavirin has been shown to improve the second phase. So the thing is that once you get down to this limit of detection in the serum, we really have no idea what happens. We know that people have different second phase slopes, and we don't really know whether they continue to follow the trajectory when they cross this lower limit of detection, or whether that line changes. Part of it is we don't have a lot of data, and secondly, it's not easy to collect because this is a bit of a black box once you get below the limit of detection in the serum. So what do the models predict? Well, if you take these models, and this is again work from Alan Perelson's group, that in a population of patients that are 100% adherence, and this was done just with telaprevir monotherapy, the probability to eliminate the last viral particle, once you get to about 7 weeks, you basically have a 95% chance that you will have done this across a probability. This is just a distribution of probabilities of some of these parameters. And this is assuming 100% adherence with the black line or partial adherence with the red line, and that no resistance. So obviously that's not true for a single DAA, but it actually is pretty accurate for a combination of DAAs. And if you look at the ION-3 trial looking at sofosbuvir and ledipasvir, you can see that, well, lo and behold, 8 weeks does look like it cures about 95% of people. So more or less fitting with what the theory was, that you should be able to do this in a general population. But it's never that simple. You can't use these modeling things to just give you such a quick answer. And this study, which came from the NIH, I think was helpful in illustrating why it's more complicated. So this was a study that compared sofosbuvir ledipasvir for 12 weeks, or triple combination, so sofledipasvir plus either a non-nuc polymerase inhibitor or a protease inhibitor given for just 6 weeks. And you can see that the 3 lines, so sofled is here in the red, and then the 2 triple combinations in blue and green. And you can see that the first phase kinetics are identical. The second phase, by adding this extra mechanism of action, you may have a slightly faster second phase, but it's a little hard to interpret. But the results are very interesting. So if you looked at just the kinetics alone and you did the same exercise that Alan Perlson did with telaprevir, he would have predicted that with 6 weeks of therapy, you would have had a 7% SVR rate in group B and a 26% SVR rate in group C, the slightly faster kinetics. But when you look at the end of treatment, this is very interesting. In the soft lead group, in group A, everyone was negative. In group B, 12 out of the 20 still had detectable virus in their blood, and in group C, 50% had detectable virus in their blood, but there was only one relapse in the whole trial. So all of these people achieved SVR despite having persistent viremia detectable at the end of their 6 weeks of treatment. So that means if they have detectable virus in the blood, there's at least 5 to 6 logs of virus left in the body, yet they cleared. So what does that mean? Well, it means that either immune clearance still happens with drugs, or the second possibility is this detectable RNA that you're finding is actually non-infectious RNA, and we know that in vitro at least about 1 in 100 virions is infectious. In vivo, we don't really know whether that's higher or lower. Drugs certainly may change that ratio, but this is really the two possibilities. So this introduced this concept of having, now you have the lower limit of quantification or detection in the serum, you have your cure boundary, and in between you have something which you might want to call the immune boundary, which basically changes this trajectory. And it throws off your predictions because we have a relatively poor understanding of what is this immune boundary and how it varies from person to person. But it does mean that kinetics alone are probably not going to be enough to predict for a given individual because you don't know enough about their immune system. So it means that we are probably going to end up over-treating most patients. And if you look at this, so you say that this immune boundary, we don't really know where it is. It probably varies from patient to patient, so that's why I've drawn it as a bit more of a bar and not as a single line. But if you take, this is our standard treatment duration for most populations of 12 weeks, and you can see that this covers most of these second phase slopes to get down to the lower limit of detection. Now, if you shorten that to 8 weeks, you still cover most of them, especially if this immune boundary helps you, but you may not cover quite all. And when you get down to 4 weeks, importantly, you still cover some of them. So these patients with a rapid second phase decline, whether or not that's added to by their own immune function, you still should be able to cure some people with very short therapy. And in fact, that is the case. But you clearly will not be able to do it for everybody. So this tells us that the 12-week therapy is sort of like over-treatment. So shorter durations will still cure some people, but not everyone, and the little things will matter. And these are the things which are easy to talk about, but really very hard to quantify. So the effect of cirrhosis, the effect of adherence, which will affect you more in this group than when you have longer therapy, you'll have more reserve. They're probably their baseline genetics, and also the presence of resistant variants that may have a very modest effect if you overtreat patients, but have a more profound effect when you try to shorten therapy. So what happens with effective therapy? Well, we know these are the ION 1 and ION 2 trials with sofosbuvir, ledipasvir, and you can see that almost everyone's cured with 12 weeks. You can see if you're treatment experienced or if you have cirrhosis, you need a little bit longer therapy, or you need ribavirin, which seems to improve the second phase slope. But this isn't just in clinical trials, this is also in real world. These are just a couple of studies showing real world results with either soft lead, with or without riba, or peritapavir, umbidisvir, dasabuvir. And you can see that in all of these really outstanding results, 95% of people are cured with these therapies. So I guess I would say, well, we're not that good. To get such excellent results, most people do not need 12 weeks. So our patients are not as adherent as we think they are. We are not probably as good at taking as care of them, in a sense, as we might like to think we are. So the fact that we're doing this means that we are over-treating most people. So there's definitely variability in the viral kinetics. And so effectively what we're doing is we are treating to cure the slow responders, and by curing the slow responders, we also cure all the fast responders. And that's kind of the strategy that we've taken to date. So if 12 weeks is over-treatment, well, how short can we actually go? So there are a few approaches you can think about to shorten therapy. So let's look at DAAs alone first. So here is grazoprevir and elbasvir combined with sofosbuvir. So 3 classes of drugs, very potent drugs, and In this trial, they tried looking at 4 weeks, 6 or 8 weeks, and you can see that even with this very potent regimen, so on the negative side, only 33% of people responded, but the important thing is 33% of people responded. So actually 10 people were cured with just 4 weeks of this very potent regimen. Clearly it's not enough to implement this broadly, but it is interesting that you could do it. Now, if you use a similar combination of 3 drugs, also a polymerase, an NS5A, and a PI, again, 4 weeks does about the same. So you find this sort of threshold where you can cure a small percentage of people with very highly potent therapy for just 4 weeks. But that's clearly not enough for everybody. So if you are going to try to shorten therapy, then there are a few ways you can do this. Maybe you can choose based on baseline characteristics, or you can look at on-treatment responses and try to tailor your therapy that way. And so this has been done to some degree. So the first was, the very simple approach was looking at the viral load in the ION studies to when in ION 3, when duration was shortened to 8 weeks. And you can see that the SVR rates actually don't really differ between 8 weeks and 12 weeks, even in patients with a high viral load. But what does differ is the relapse rate. So patients who only got 8 weeks of therapy, if they had a viral load above 6 million IU per ml, you can see that they had this higher relapse rate, which is why the FDA and European guidelines recommended for patients with a high viral load at baseline that they should get 12 weeks of therapy. Now, importantly, the HCV RNA is not a simple measure. It actually is a measure of your immune function in a way, because this is the equilibrium that your immune system has come to with the virus. And so that probably is more predictive than just starting out with more virus takes longer to get rid of it. It probably is also some degree of measure of immune function. So there are actually other ways to select 8 weeks rather than using just a viral load cutoff, and arguably they're better. So you can use, if you actually look at female sex, the interferon lambda 4 genotype, and to a lesser degree fibrosis, but actually these two characteristics are actually more predictive than the viral load threshold of 6 million. And the other reason that they're arguably better is that these are fixed, they don't change. Whereas the viral load is something that is very variable depending on the assay. Even on the same sample, you can have up to about a quarter log variability, which means that you can have a pretty big range in your viral load if you just measure it on a single occasion. Now, that being said, the real world results are very good with this. You can see that 8 weeks actually does look very good, not just in clinical trials. These are real world studies showing very high effectiveness using this 6 million threshold. So it obviously is pretty good, even if it perhaps could have been a better designed approach, I think, from the regulatory evaluation of these trials. So if that works, maybe we could use that to try to identify who could get these very short therapies. So if we go back to that trial I showed you with SOF, Grizoprevir, and Elbasvir, so the triple therapy, and you look at the people that got 4 weeks and you break them up based on their viral load and based on their IL-28B genotype. And what you can see is that the ones in yellow are patients that relapsed, the ones in green achieved SVR. And you can see that the ones with higher viral load, so high viral load predicted failure very clearly. And although patients with those that did have an SVR tended to have a lower SVR, had a little more likely to be IL-28B/CC, you can see clearly there's a big mix here. So this is not predictive enough to be useful for selecting your patients. It's thought-provoking, but it's really not adequate to do anything with patients. So if you can't use baseline factors like the viral load, what about if you choose a specific population? And this was a study that was just at ASLD this year, which I thought was very interesting, mostly because the results were, to me, somewhat astounding. So this was a study done in Denmark where they gave 4 weeks of sofludipisphere and ribavirin, in this group without PEG interferon, in this group with PEG interferon, but 4 weeks alone in a group of patients who were active injection drug users, and they were genotypes 1 or 3 predominantly. There was one with genotype 2, all treatment naive and all with mild fibrosis. And you can see actually in this study there was only one virological failure. So we would not have predicted that this therapy would have been as good as that, and really no trials to date have shown such high efficacy. 4 weeks of this therapy. This is without interferon and still getting everyone except one to have a virological response. So it's a single center study. It's interesting. I don't think this means that we can use this regimen in broadly, I do wonder whether maybe these people, because of having repeated exposures through active injection drug use, have some degree of partial immunity, which allows them to clear. I'm not sure what it means, but I think it's interesting, and it's thought-provoking at least to think about choosing your populations. If you can't choose them at baseline, maybe you can choose them based on therapy responses. And this was a study that was done in Hong Kong looking at very early viral kinetics. So what they did is they took patients who were genotype 1b, were non-cirrhotic, and they were all Chinese, and they were given they were given 3 DAAs, either sofosbuvir with a protease and an NS5A inhibitor, and they looked at their viral load at 2 days, and what they found is that 13 out of 18 had a viral load less than 500 IU by day 2. And all of those got only 3 weeks of therapy. So if they met that threshold, less than 500 by day 2, they truncated therapy at 3 weeks, and all of them achieved SVR. The patients that still had a viral load above 500 at day 2 continued for 12 weeks, and they all achieved SVR. So actually in this study, using a very simple measurement at day 2, they were able to shorten therapy to 3 weeks in the majority of patients, which is quite remarkable. Now importantly, these were all genotype 1b, they were all Asian, and they almost all had IL-28B CC. So here you weigh the complexity versus shorter therapy. Now this is what I said about cost saving. In the instance in China where these patients are buying the drugs for themselves, this has a big benefit. If they only have to pay for 3 weeks of drugs instead of 12 weeks of drugs, and they're paying for it themselves, then it really is cheaper and it really does save them money. But at a programmatic level, I'm not sure that the complexity of this is actually beneficial and worth the benefit. So the alternative is you sort of overtreat, but you have a very simplistic therapy that works for basically everybody. This is showing you soft valproatovir, and this is in combination soft val for 12 weeks versus trying to add a third drug, adding voxilaprevir, the protease inhibitor, and giving it for 8 weeks. And you can see that although the SVR rates are still excellent, the relapse rate does increase in the group getting the voxilaprevir. I'm sorry, I've mislabeled that. And there are other pangenotypic regimens coming down the pipeline with either a protease, an NS5A, and a nuke, or even just a second-generation protease and NS5A inhibitor. And so these look like promising regimens, which might allow us to get to 8 weeks, but I guess I'm just not sure if that's going to be worth the benefit. Maybe it is, maybe it isn't. And I'll go through this very quickly just for time. Is there any rationale for thinking about other approaches? We could still think about host-targeting drugs. I think probably 8 weeks or maybe 6 weeks is the threshold with DAAs alone if you're going to use it in everybody. And if you want to get shorter, you'd probably have to do something else. So one possibility is to add a host-targeting agent. This is a complex diagram showing interactions between viral and host proteins, and it's intentionally complex, but any of these host proteins could theoretically be a target that you made a drug for. MicroRNA 122 is not a host protein, but a host factor that's important in HCV replication. The virus binds to microRNA 122 and it stabilizes its RNA. And so inhibiting microRNA 122 has been shown to be an effective approach to inhibiting HCV replication with miravirsin, which was a first-generation miR-122 inhibitor, and you can see nice viral suppression with this drug. But that drug didn't go through further development, although this is a better microRNA 122 inhibitor, mostly because it's GalNAc conjugated, meaning it gets very high uptake in hepatocytes. And in this, giving just a single injection of this drug, it's very long lasting. You can see you got very good RNA suppression, and in fact, the majority of patients became undetectable with just a single dose of this drug, but you do see that many of them relapse, so probably not as good as DAAs. But this was a provocative trial where you get a dose of this microRNA 122 inhibitor, and then you get DAAs for 4 weeks and a second dose, and you're done. So 4 weeks of total treatment. And you can see in this regimen where they gave soflodipisphere for 4 weeks or just a single DAA, even a low barrier drug like decladisvir, and you can see that these SVR12 rates are pretty remarkably good in not that small a trial. The problem right now is that this drug is on hold for toxicity, but I think it does, at least it's thought-provoking as a strategy to really get to short short therapy if we wanted to do this. It also provides a very high barrier to resistance in groups where adherence may be an issue. And I'll skip over this one. So I think shorter therapy is potentially attractive, but only if it's equally safe, effective, and simple. Cost alone should not be the primary reason to shorten. Pricing really should be per course rather than per pill. And modeling predicts that most will need 8 weeks of therapy or less, but getting to less will require some selection. To go below 8 weeks with DAAs alone, you're really going to need either some kind of baseline predictor on treatment response, and you're very unlikely to get to a one-size-fits-all. I'm not really sure that the complexity is worth the effort, especially if we're talking about elimination at national or even global levels. And to get to 4 weeks or shorter, we're going to need to do something other than just throw DAAs at Hep C. Thank you very much.
I think there is one alternative that you didn't discuss, which is really keeping the same exposure but reducing the doses. And I mean, that's what's now being done in HIV, where we have long-acting drugs. Mm-hmm. So you could think about depot preparations that you keep once, inject, and then the patient goes home. You don't need to check him, and he's cured. So.
Yeah, I think that's an interesting idea. I was going to talk about depot, and just for the sake of time, I didn't, especially because in Hep C so far there are no data on using depot. I think it makes sense, and you could argue it makes more or less sense in Hep C than it does in HIV. It makes more sense because you could have a single injection and be curative. It makes less sense because you've got a curative therapy and you don't need long-term, like the reason in HIV the depot therapy is so useful is you might only need to see someone every 3 or 4 months for their depot injection, and then they don't need to take pills all the other times. Whereas for Hep C, they've just got to be cured once. You don't need them to keep coming back. And if there's any issues with toxicity of the long duration with the depot, that's really questionable of benefit. I mean, I think it's interesting. I think it should certainly be explored, but at least I'm not aware of any development of Hep C depot preparations.
Thank you very much for an interesting talk. You didn't mention age as a potential baseline predictor.
Yes.
The Danish studies today, her population was very young, and these phase 3 trials, most trials, mean age is around 50 years old. What about the people who are in their 20s?
Yeah, it's a good point. Although, if I'm not mistaken, I should have made, sorry, I was in the audience here, but did this very provocative trial with the 4-week therapy. But I thought the mean age was actually 39 in your trial, wasn't it? It was. Yeah, because I was struck that it wasn't as young as I thought it was going to be.
No, that struck me as well. I thought it would get them younger, but what actually sort of kept us going on with this trial was that the other 4 weeks DAA trial that has failed had considerably older population, and they were also somewhat fatter or had a larger BMI, and our people couldn't be obese. They had to be less than 100 kilograms. But I'm absolutely agree with you that this is done in a P-weight, probably multiply infected population that have a different immunity, so you should be very cautious about extrapolating data from that. But of course, it was very encouraging for us to see the results.
Great, absolutely great study. I think you're right that age almost certainly does play a role, as does, I think the problem is that none of these factors are adequate enough to predict for a patient how long you need. So if you have someone that has a favorable IL-28B, is female, and is younger, that person is probably going to be able to have shorter therapy, but how much shorter? And then are subtle things like adherence going to matter more? The baseline resistant associated substitutions, are they going to matter more in that patient? And I think it may just be very difficult to come up with an approach where you can really select the right duration for the right patient. And probably the strategy is still, with the safety of the drugs, to overtreat most people.